I've thought about our questions in a number of contexts, and perhaps just to give our speakers a little bit of time to crystallise their thinking after those terrific conversations. I suppose the three areas that I want to sort of align or align the questions to is firstly that commitment that we have across the range of health and community policy and delivery sectors around moving away from a siloed approach to our patient client-centred approach, and that's really, I guess, sits behind the integrated care that we've heard more about. But alongside of that is the capacity building and governance transformation that's required of the organisations that are engaging as well. So I want to think about that context. And the third context, I think, is just thinking about our Australian context, and that is that there are many across our communities that will find it difficult to fully participate in the health and wellbeing opportunities because of their circumstances due to either geography or other forms of marginalisation. So just thinking about those, that kind of more, the marginalised context as well. So Tim, let me start with you, and in some other contexts we sometimes talk about, what's the first 90 days like? Now, it's not quite been that, although it's only been 2 weeks in the current role, and I must say I'm probably still reflecting a little of the fact that I'm only just back 2.5 weeks from having some long service leave in the UK, and one of the things that I keep reflecting back on is that when you put yourself in another global context, there's lots that you can identify that we are the same about, but there's also lots that we're different about. So I wondered whether, against that context, and particularly there's two areas that I think Claire raised that you might perhaps give us your wisdom about, how much are we the same and how much are we different? So one was, Claire, in the early part of giving us some history, you referenced the fact that we've done a lot of observation, we've done a lot of reporting, we've done a lot of piloting, but we don't mainstream, and you reflected something of a 30-year journey in integration. So that's one, Tim. How much are we the same, how much are we different? And the other was in, I guess, more of our structural context, so multi-layered government, multi-income streams, health insurance as a contributor.
Yeah, well, thank you. Is it on? Yeah, well, first of all, I'm obviously really sorry that we beat you at the rugby. I'm sorry about that. That's the only thing I hang on to as an English person post-Brexit. The rest of everything else is going wrong. Actually, the Olympics were good, but it's really interesting because there are so many real similarities. I don't think actually. I'm not sure the NHS is really a particularly good analogy for Australian healthcare, but there is lots that it tried and didn't get right, which I think could save Australian healthcare quite a lot of time. But I think there are other analogies, and Claire mentioned the Australian experience and, some fantastic integrated systems, Geisinger and others, which really do, I think, pave the way for all of us. So I think we need to be just mindful of that point, that I don't come from England bearing any particular insights which I think are necessarily going to transform Australian healthcare. But I think there are two things which so one of the big turning points for the English NHS was when we put all the pilots back in the Air Force. And we said that we were going to stop doing pilots, which are essentially ways of validating national policy by handing out large tranches of cash to local health economies and essentially trying to make them do what the system wanted them to do. And they were called pilots, and we don't talk about pilots anymore. And instead we introduced, and I think this is what Healthcare Home is absolutely right on the money with, is rather than sort of going with a particular position on new models of care to a local health economy, instead to support the local health economy to develop the new models of care in ways that are appropriate to local need, and to leave the autonomy for design to that local health economy. And there's a big programme in the NHS, which I'm sure Claire and many others are familiar with, around new models of care, vanguards, test beds, this whole process, which is really about, and my former chief exec has spoken very widely on the subject. It was really about kind of, frankly, unleashing the energy of local health communities in some ways that only national enterprises can, but not putting them in a position where they're essentially just validating national programs. So I think Healthcare Home, the way I've understood it at least, when you're in my conversations with local PHNs and with local states, is that this is being regarded as an opportunity which is very much about the centre supporting local energy to transform services for patients. So I think that there may be a similarity there, and perhaps Australia has also reached the point where kind of the idea that you get local health economies to pilot national policy is going to be something that doesn't resonate for much longer. I think that's a really important opportunity with Healthcare Home. I'm going to be slightly controversial with this, and I don't want this to be misread, but an observation about a difference is to do with transparency. So I've spent the better part of 15, 20 years promoting the evidence. I hope Claire would agree with me that actually public reporting of outcomes in healthcare does improve the quality of care provided, and the evidence for that is increasingly good. It's obviously a difficult and complex journey, particularly when you're talking about physician disciplines. How can you measure and compare the outcome of general practice, for example? It's a very complex and real scientific challenge. But nevertheless, the English NHS, as I'm sure everybody in the room knows, has prioritised publication of comparative outcomes, avoidable mortality rates, and so on and so forth, as a core part of its reform agenda, and in fact has been doing that now for the last decade or so. And I look at the situation in Australia, and the facts are really straightforward. The facts are Australian healthcare is better than English healthcare and is cheaper. And yet there is very little transparency that I can see in relation to outcomes provided at a local level. And we're still, as Richard Roy was reflecting earlier, in a situation where you kind of have to know which the good doctor is, and if you don't, you ring your friend up, and that culture, which is one of the priorities we try to put behind us in the NHS, and of course it's a long journey. So I think for me it's kind of we similarities in the way where both countries are reflecting, both health services are reflecting on how they can genuinely promote sustainable innovation into the mainstream, I think is real. I think that's where I think an interesting question is just the role of transparency in healthcare delivery, not something I think Australia's necessarily taken on in quite the same way as in England, and maybe it doesn't make much difference, but I just observe that as a difference.
That's good. And Claire, maybe throwing to you, particularly picking up that comment of Tim's around perhaps a lesser amount of publication of outcomes at a local level. Is that your experience?
I think we probably need to take a leaf out of Greenpeace's book and think global but act locally. I think that's the big problem. As I said, that our governance and funding systems are just a complete non-fit at the local level, which is where the patients and their families live. So I think looking at those two and opening up opportunities to funds pool, to look at a common vision, to really unleash the opportunities we now have with local hospital networks and primary health networks having overlapping of boundaries with really good relationships with their state governments. I think it's just going to be a missed opportunity unless we grab that tightly.
That's great. Can I test if there's any questions from the floor?
Hi, my name's Danielle Jewell. I'm from People with Purpose. I guess, Tim, you might not be able to answer this question, but I'm wondering if there's a lesson to be learned from earlier in Australia's history where we allowed the states to decide what kind of rail network they wanted to design, and consequently they decided on different width gauges that created some connectivity problems. What consideration has been given to the unintended consequences of the healthcare at home policy allowing for that local customisation, particularly from a information sharing and transparency and integration point of view? So I'm interested in what consideration has been given to perhaps some of the unintended consequences of a localised but fragmented approach.
Well, I think that's a really good question. And interestingly, I reflect, it was only, I think, about the 1860s that, for the same reason, England actually established a common watch time across its nation, because the railway timetable determined different times in different towns and cities, as people may know. But I think the lesson, which is the one that is certainly what the agency has been set up to deliver, is that there needs to be a small but really tight set of national digital standards, data standards, that will allow for the interoperability of data, the communication of patient records across jurisdictional boundaries, whatever the shape of the electronic record provision might be in a particular locality. So the challenge which I think everybody, both the local state health services, certainly the agency, Commonwealth Government, is focused on, is kind of agreement on those standards and co-production of those standards, so that people are able to empower local innovation, but within the context of some quite tightly agreed and respected national standards. Because, I mean, for obvious reasons, it would be unthinkable if we ended up in a situation where health data could not flow across jurisdictional boundaries, and that certainly is absolutely the priority that I think all my colleagues have got. I would also just reflect on one other quick point, which is that kind of whichever way you look at it, given the fact that every other industry you can think of has already been through this process, come out the other side, realise that it grossly improves customer experience and satisfaction and reduces overhead. We have to get the basics right, not just because if we don't, people will be harmed and are being harmed in Australian health services, but because we will not be able, certainly in the public service, at least the public health service, to offer next generation genomic diagnostics to patients in Australia. And for me, the best argument for both adoption of core digital standards across a country and indeed arguably for universal healthcare is that the arrival of genomics and new diagnostic sciences, precision medicine, cannot be delivered if we do not have electronic records that flow with some complexity across the geography of a nation.
Thank you. Question over here.
Hi, Mal Thatcher from eHealth Queensland within the Department of Health. Hi, Claire. This question is directed to you. What do you see the future role of the primary health networks, both in terms of the healthcare home, but I think longer term in terms of moving towards more a population-based health funding model, where we're trying to move away from input-based funding to outcome-based funding?
And I put up that grid of Carolyn Nicholson's, which identifies, I think, the huge cross-section between primary health networks and local hospital networks at the moment in terms of taking a much greater integrated role around looking at their population. So instead of one set of what the primary health networks having a needs-based assessment looking at the population here, and the health and hospital service having a needs-based assessment of the same population, I think we're increasingly working together. I think over the next 5 years, I see primary health networks taking much more of a leadership role in the community in terms of commissioning services, but also integrating services within the community, but being a spokesperson for how that conversation might happen with health and hospital services. And there are a number of pundits saying that maybe in 10 years' time, we'll have one regional health authority rather than primary health and local hospital, if we all can really work out the governance and funding rules appropriately. So one population would actually have a one-stop shop for its policy and service delivery approaches.
Thank you.
Hi, I'm Chrissy Norton from Health Developments Corporation. This is again directed to Claire, probably. We're very interested in and admiring your dedication to the healthcare home model. I see the funding structure for that is largely administrative at this point in time, and there's a heavy reliance, I believe, I'm not an expert, on private health insurance to be involved in funding the actual service provision in that agenda. How do you think that works in socio-economically disadvantaged communities where there's low health insurance rates and there's no incentive for that funding?
So I think in the vacuum around healthcare homes over the last 2 months, there have been wild rumours. The patients in medical home actually grew up in the most vulnerable populations in the US, and a number of our Harkness Fellows have worked in that environment. So it is definitely focused on high access for needy groups. We don't know what the healthcare home pilots are going to look like. Metro North does, because we've been working on ours for 2 years. And it's quite clear that there will be funding required for transformation of really primary care providers, not just in the practice, but across the community as well. And there will then be service delivery funding. At the moment, there is no discussion about the quantum of that funding, where it will come from. Our understanding is that there is currently a large amount of funding that goes into chronic disease management and general practice, GPMPs, TCAs, mental health plans, reviews, nurse items, PIPs, SIPs, EPIPs. When you bundle all of those up, that's a very significant amount, but not every practice is able to access those. So we already have a significant amount of funding there. State governments are spending a lot of money on people with preventable hospitalisation. So the average cost of one night in hospital is $2,500. And they're spending a lot of money on people in outpatients. So the average cost of being seen in an outpatient is about $800 in real terms. So it's really getting a little bit more leverage around what we spend as a huge quantum, but redirecting it so that people get care in their community at the time they need it, in the way they need it. People don't want to park their car, pay for parking, and that's really old school. We don't do that for banking, we don't do that for shopping, we don't do it for anything else anymore. But because the business rule is you don't get paid unless you actually have someone sitting beside you, we don't do it. So we could do extraordinary things, but the point of my presentation is today is we're locked into a 1970s model. No one has said that private health providers are going to be funding the healthcare home. We have certainly involved all the private health providers in our area in having a place at the table, so they should. 47% of our population have got private health insurance, but again, because of the business rules, they can't draw down on any benefit from that in an emergency department or in the community. And they need to be able to. And if people have funding through their health insurer and it is appropriate to their care, then it should be on the table as well. So it's unfortunately very much a watch this space. The department has 4 work groups beavering away on healthcare home at the moment, and an implementation group that will meet again next month. Meanwhile, lots of parts of Australia, those within primary health networks that are on the hit list and those that are not, are busy developing their own models because they, with their health and hospital service, can see this is the only way to provide tangible resourced services into the future.
Thank you. Question? Richard.
Richard Royal, immediate past acting CEO of the Digital Health Agency. My question, Tim will be delighted, is actually to Claire. Claire, to what extent do you think the success of the healthcare home pilots is going to be reliant on the provision of integrated data?
Richard, you're going to really hate my answer. I think technology's an enabler. It's definitely not the main game. And yet because it's really sexy, we get really obsessed with it. Whereas the boring old stuff is really sitting with people, listening to what their problems are, thinking about things around the better way of delivering services. It certainly helps, and having data at the point of decision making is fantastic. General practice now is probably the most computerised part of the healthcare industry, so most of my colleagues would be functioning in a paperless practice. If I'm in Metro South, I have a portal straight into the MARTA, so I can go and look at anything I might need from any care my patient has been receiving there at the hospital, and then dump straight out into my systems from that hospital. If I'm in the remote part of the Northern Territory, I can do amazing things with my technology. If I'm in rural New South Wales, I can probably do far less. I was very struck with our National Demonstrations Hospital program 10 years ago, when we had 33 hospitals working with us around really getting good benchmarks out of the emergency department, and the performance measure was set that within 48 hours, a legible, relevant health summary had to be out of the ED and into the general practice. And there was only one hospital that actually had that strike rate. It had the least technology-enabled infrastructure, and it used Australia Post. And we laughed at them when they said that that's what they wanted to do. But they actually looked at what they wanted to share, what was important, and what worked best for them, and then they used a transmission that enabled that best. So I think, of course, we have to involve e-technology, and we really must be investing in it. But it isn't the bee's knees, it's a facilitator rather than being the main game.
Question at the back.
Hi, it's Alicia Wooding from Blue Care. We've talked a lot about hospitals and GPs and integrated care, and I was just wondering what consideration there has been for residential aged care, particularly with our ageing population.
Shall I? Well, so in terms of, I can't really speak from an agency perspective on this, but in terms of the work that we've done before, we slightly disagree, the NHS has slightly disagreed with Claire's position on the need for integrated data to be able to do things like sensibly risk stratify cohorts of patients in order to reduce their demand for hospital services, and actually we have not seen improvements in cost reduction or in quality without those data being available to particularly GPs, and in particular what that has in the NHS has done is open the channel, as it were, of thinking about integration, very deep integration with aged care services. Now I'm learning, as I say, the Australian situation, but in the UK, the kind of equivalent of the jurisdictional difficulties that sometimes obscure integration in this country, state, Commonwealth issues, and so on, are kind of mirrored in the relationship that the NHS has as the health provider with the local authority system providing social care services alongside it, where there is an absolute gulf of data and accountability. And so trying to bridge the gap has been a really important part of improving services for elderly people in particular, and also crucially in helping the NHS support them to live independent lives as far as they wish in their own homes. So I think that this is going to be one of the biggest priorities for the agency, although as I say I can't speak for that right now. And it is a place where technology, the Internet of Things, sensors, without sounding ludicrously futuristic, actually do offer a very real right now opportunity. We've seen Kaiser Permanente, for example, deploying a range of technologies which are evidentially improving outcomes for people in aged care. But the point of your question, I think, which is why is aged care always the Cinderella of healthcare services, is a really well-made point. And let's have this conversation in a few months' time. But clearly, it's an area which just can't remain in that position.
So residential aged care is a real hotspot. What do people in residential aged care and their families and carers need? They really need excellent connectivity for advice. They don't want to move that person, where possible, into hospital, where they do very poorly in general, and where they're in unfamiliar surroundings, which can actually, of its own account, reduce their level of function. So Queensland Health has been very involved in video conferencing support into residential aged care, and we see that now moving much more into a healthcare home potential initiative now that all the problems are sorted. Having an advanced health directive is another critical thing that really helps families so that care can be delivered according to that patient's wishes in the setting that is most appropriate for that patient. And I think the opportunities around polypharmacy and deprescribing, once again, having clinical support coming into residential aged care rather than moving the patient around, is very much enabled by having a healthcare home and a pharmacist within the healthcare home, which is our preferred model.
I think we've got time for one more question.
Hello, Marianne Wallace, Professor of Nursing from the University of the Sunshine Coast. I have a quick question to both speakers. My first question was actually asked by the Blue Care lady, well done. But I would like Claire just to comment on the role potentially of nurse practitioners in that space if we could actually increase the Medicare billable items to more than $50 and $8.
I think we just get rid of the Medicare billable items and instead say, for this person with this complex chronic condition, this funding is available to really support the team around them. And I think nurse practitioners definitely have a role in the team, not just for aged care, families with children who have developmental problems, ADHD, various other things. The model in this country has been somewhat restrained by the cost of nurse practitioners, so funding and salaries are much higher than they are in the US, and so particularly in primary care that's been a huge limiting factor. But I think, again, if we're looking across the team and funding to support high quality teamwork, then allied health pharmacists, nurse practitioners, there'll be lots of people, depending on the patient's premier need, that will step up to the fore and take the key role for this quarter or this 6 months or this year. So yes.
Great, thank you. And one quick question to Tim. Given Australia's great hesitancy about security of our electronic records and the recent experience with the census, for example, how are you going to market? I just did a straw poll round our table, and I'm the only one with a My Health record here. So how are you going to market that to a security-conscious Australia?
Yeah, well, I was waiting for that question. I think this. Perhaps I'm not qualified to have an opinion given the relatively recent stage, but I think the census issue will change perceptions quite significantly, particularly appetites for kind of amongst politicians for this. I mean, my own personal journey has taught me that this issue of how people, of public trust in a public service as important as healthcare, and the way in which that service is going to do everything within its power to protect an individual's confidentiality and respect that person's confidentiality in an age when, frankly, we can't predict how these, hackers, how different digital terrorists will try and undermine that confidentiality. So it's a really tricky situation, and for me the answer is in total transparency about both uses to which data are put, ways in which safeguards are erected, and there's a big, I won't go into all the detail, but I think the lesson from the NHS and my own personal experience of it is that people understand the risk in a digital age. They want to know what a public service, a public authority is doing to the utmost of its ability to ensure confidentiality of their data. And crucially, they also want to know what benefit that data is being put to when it's being shared for research or whatever other purpose. But they do have to have the right, if they do not trust the public authority, to be able to decide that they don't want their data to be shared. And this is a really difficult and complex conversation. There is a secondary data uses consultation out currently in relation to sort of Australian data sharing in healthcare. I hope that this debate can be a measured one because it needs to happen and it needs to happen in public. But I think that the answer is, just as I said in my talk, is that patience, some political courage, a really clear and accessible debate is the only way in which you can surface the issues that need to be addressed in relation to confidentiality of data. And it's one in which we all have to be involved. It's bigger than healthcare, but healthcare is where I think the rubber properly hits the road when people start to really reflect on who they want to see their most intimate data.
And maybe if I could add to that, what we would hope in health is not to have perfection, because we all know that's impossible, to have something that's better than what we have now. And so I'm reminded when I lived in the UK and Sting had a motor vehicle accident with his girlfriend and wandered into one of the regional hospitals and was hospitalised. And of course everyone wanted to know what the injury was, etc., etc. Within 12 hours, the local paper had the story, full story. It went on up, and then every tabloid in the UK had the story. And because that hospital had a electronic record, it was immediately apparent which 5 members of staff had accessed the electronic record and drawn down that data. And so they were identified and sacked. Now, and then the union was up in arms, and so they came back again. But I was imagining if Sting was in Blackall Hospital in a paper-based record, how many people would have been able to access all the details around that event? And so I don't think we're ever going to get perfection. The young woman whom I showed in the second slide, I think her worry won't be about if someone looks in her record. I think her worry is if people aren't looking in her record and understanding what critically important issues need to be shared with her or her family. And so sometimes I think we overplay the need for complete foolproof perfection in privacy and lose the extraordinary gains that we have over and above what we have in our system at the moment.
Thanks, Claire, and I think that's probably an appropriate time to draw together, because I think you reminded us at the beginning, and in fact, Tim, you reminded us in the opening of yours that our healthcare system is about that personal level of care, and we can have the most perfect system, but if we're not actually paying attention to that, then we've missed our calling. So thank you to both of you.